Good afternoon, everyone across New Zealand. My name is Matt Eby, and I'm a Regional Manager of Support Services for Leukemia and Blood Cancer New Zealand. I'm based here today it's sunny Christchurch. So welcome from here. And I can say it's definitely a special privilege to have Professor Peter Browett back again, as he actually kicked off our winter-spring webinar series a few months ago. So as well, today's presentation was timed to commemorate CML Day, which falls on September 22nd every year. So that was just Tuesday, just gone. Okay. Just a little bit of an intro here for those of you that haven't seen him present before, but Peter is a professor of pathology and head of the Department of Molecular Medicine and Pathology at the University of Auckland School of Medicine and a consultant hematologist at Auckland City Hospital. His involvement with leukemia and blood cancer in New Zealand stems from his clinical interest in the management of patients with hematological malignancies, including blood cell and bone marrow transplantation. In the laboratory, he has an interest in cell marker and molecular studies in the diagnosis and monitoring of patients with leukemia, lymphoma, and inherited blood disorders. Peter has had a long association with LBC, acting as our medical director and trustee for many years and more. Recently joining the LBC's Independent Medical Scientific Committee, overseeing research grants. So it's a fabulous welcome to you, Peter, with a presentation titled CML and Treatment Updates. So I'm looking forward to this as well. And before I turn it over to you, just say this to anyone joining us across the country from your homes, offices, wherever. If you just look at the bottom of on the bar, pretty close to the middle is a Q&A. So as you're coming up with questions, just type them in, and then we'll get a chance to answer them at the end of the presentation. So with that, Peter, I turn it over to you, and welcome.
What I want to do today was talk about chronic myeloid leukemia and what is new. And as Matt had sort of said, it's appropriate that the talk is now because we've just passed World CML Day, and that was the 22nd of September. And you go, well, why is the 22nd of September World CML Day? And you have to remember that in North America, and particularly in the United States, is that they're always backwards. And so they put the month first and then the day and then the year. So on Tuesday in the US, it was 9/22 sort of 20. And of course, the 9/22 is the hallmark of chronic myeloid leukemia, is that this is the key abnormality within the bone marrow and the leukemia cells is this translocation where bits of chromosome 22 have gone to 9. So you can see this extra pale bit here, and part of 9 has gone to 22. It's called the Philadelphia chromosome. And that's really what drives this leukemia and what has changed all our therapy. So that translocation, which is not an inherited one, it's only in the bone marrow cells, it puts together the BCR gene from chromosome 22 along with the ABL gene, which we all have these, but one sits on 9 and one on 22. It puts them side by side, and that's what drives the leukemia. So the protein, so that's the actual enzyme that comes from that gene. So the gene is the instruction part of it, and then the protein, this BCR-ABL protein shown here in blue, that then switches on a whole lot of other pathways in the bone marrow cells and makes them grow. And the big breakthrough, the big discovery was that drugs such as Imatinib, and that's shown here in green, it was designed to specifically bind onto the BCR-ABL protein, and it blocks all those dry pathways, and it makes the leukemia cells drive. So the first example of a targeted therapy that was designed around understanding the genetics of the leukemia. And just to put this in perspective, so the advances in this field have been massive in a small number of years. So on the top of this in blue are the laboratory discoveries. So when you go back in history, probably these scientists were talking about chronic myeloid leukemia, but it really was 1960 that the Philadelphia chromosome was discovered, and then in the 1970s and 80s that we figured out what that meant. So that was the laboratory work. And then in the late 90s, the first work on inhibiting the Philadelphia chromosome or the BCR-ABL protein. And that was a drug that we used to call STI 571, now called imatinib. And here's the things that have happened. So we've got the funding of Gleevec. Then we've got the second generation drugs, dasatinib, nilotinib. And here we've got the first time that people thought, gosh, could you safely stop the drugs in these sort of patients? And then if we look at how did New Zealand, what did we do in New Zealand? So the first patient, and I'm not sure whether she's dialed in today, but the first patient was treated on the 22nd of October 2020 and went on to our trial, which patients were randomized between imatinib and the best current treatment of the time, which was interferon cytarabine. So she got randomized to imatinib. We had no idea whether it would work or not. So these were very brave patients going onto the trial, and that patient Carol is now has had a very good response, and in fact has been able to come off imatinib. Funding for imatinib was in 2003, and then dasatinib was approved in 2009, nilotinib in 2010, and then imatinib came off patent, and we got the generic imatinibs, which we now know are just the same as the original sort of Gleevec. They were funded in New Zealand in 2013, and that brought the costs sort of down. So New Zealand's been part of all of these changes. And we now have these different tyrosine kinase inhibitors. So these are the drugs. The original one was imatinib, shown in the left, and then the two new ones, what we call second generation drugs. And it's, if you look at the arrow, here's where the imatinib binds, here's where nilotinib binds, and here's dasatinib binding here. So they're all a little bit different and vary in their potency. And it's just dramatic is that when I was training in haematology, and when the first patients went on to the Irish trial in the early 2000s, is that the survival or patient longevity in patients with CML was around 4 to 5 years, and now we consider that the life expectancy for patients with CML is similar to someone of the same sex and age when they're diagnosed. And this just shows, this is from the German CML study group, just shows the improvement in outcomes. And here there's the outcomes for patients following the advent of imatinib. And so that's the landscape that we sit in. And so in New Zealand now is that all patients with CML, when they're diagnosed, will be treated with a tyrosine kinase inhibitor, most commonly imatinib, because that's the funded drug, with nilotinib and dasatinib as second-line drugs, although we do have dasatinib for very high-risk patients. So you may say, well, what's new then? And a lot of my colleagues think that, and I think, I think there is a lot that is new, and I think it is relevant to you as patients and family of patients with CML. And to highlight that is there's new guidelines come out from a number of international societies, including the British Society, and this is the European Leukemia Network, and these just came out last month with their updated guidelines as to how clinicians should manage patients with chronic myeloid leukemia. So there are changes, and we need to be aware of that. They're broadly around the area of, when you're diagnosed, what's the best initial treatment? Because as I've shown you, we've got, 3 to 4 tyrosine kinase inhibitors. Secondly, how do we monitor patients? Thirdly, the sort of, the side effects with these treatments. So, how do we manage those? And a lot of it relates to that choice of drug. And probably the most important advance has been this new concept of the treatment-free sort of remission. And the things I wanted to highlight today, because I think they're the most important for you and for us, is around what's the best initial therapy, a little bit on monitoring, and the concept of the treatment-free remission. So if we're looking at what's new and what's new around initial treatment, it's based on, well, when a patient is diagnosed, what are our goals of sort of treatment? And the goals are, we want to have normal life expectancy for a patient that's diagnosed with chronic myeloid leukemia. We want our patients to have good quality of life with a minimum of side effects. And added to that, is the potential to avoid lifelong treatment. So up until now, we've always thought that, well, this will be a lifelong treatment, like lifelong treatment for high blood pressure or a high cholesterol level or for diabetes. But can we come off that? And so if those are our goals, what are the things we need to do? So for normal life expectancy, we need to get patients into a remission and what we call a deep molecular remission. I'll talk a wee bit about that. When we're talking about the quality of life, we want to minimize and manage the side effects. And so a lot of that is thinking about, okay, most of us have other illnesses, what we call comorbidity. So our choice of treatment depends on that. And then this new concept of, if we've started treatment, am I going to have to take these tablets forever, or is the potential for coming off sort of tablets? So I'm going to talk about particularly the initial treatment and a little bit about coming off treatment. So what's our optimal frontline treatment? So in New Zealand, we've got 3 drugs that are registered. So that's by MedSafe. So MedSafe is the equivalent of the FDA. So they register the drug. They make sure it's safe. Pharmac are the funding body. So Imatinib is funded for first-line therapy, nilotinib only for second-line treatment, so that if Imatinib hasn't worked or the side effects, and dasatinib mainly for second-line, but for what we call higher risk patients with first-line. So what about worldwide, where all of these drugs, so in Australia and the US, is that clinicians, if the insurance company will fund it, can use any of these medications? And I think it's fair to say there is still debate around haematologists as to, should you have imatinib as your initial treatment, or should it be a second generation, one of the newer drugs that are more powerful? And just to highlight this is the headlines or titles of 2 recent papers about 18 months ago in the medical literature, where there was the arguments put forward for using imatinib as initial treatment or using a second generation drug. So even in the medical community, there are different views. What are the advantages of using one of the newer, more powerful drugs, the second generation drugs? So dasatinib and nilotinib, and there's another one, bosutinib, which isn't funded in New Zealand. And there's been a number of studies that have what we call head-to-head, where new patients have either been given dasatinib or imatinib. And what the studies all show is that patients get into remission quicker and they get into a deeper remission. So the depth of remission, so that's having very, very low levels or even absent levels of the Philadelphia chromosome, or we look for the gene. And so on the y-axis here is the patients who have got a deep molecular remission. On the x-axis is months, and you can see the yellow is for imatinib and the blue is the dasatinib. But you can see more patients get into a deeper remission with dasatinib, and so that's a good thing, because the quicker you get into a deeper remission, the better that is for your for having a normal life expectancy and also for being able to come off treatment. The issue is, though, is that when you look at several, 5 years and 10 years later, the longevity of patients is exactly the same whether you had dasatinib or imatinib. And so that's why Pharmac really may put most of their funding into the imatinib. So this is the dasatinib patients, and this is the imatinib patients. You see those curves at 5 years are almost the same. So this is the percentage of patients that are still alive and well at 5 years. So there's no difference in survival. So there's a lot of people who advocate for using these more powerful drugs, but there's no difference in survival. And also there is more side effects with these newer drugs, and they're what we call off-target side effects. So although these are smart drugs, by that we mean they target the Philadelphia chromosome, is they don't just target that protein, they target other proteins as well. And so there's side effects. And what I've done here is I've just taken some of the side effects and I've compared the risk of those amongst, and this is for imatinib, this is for nilotinib, and this is dasatinib. So patients with nilotinib have more vascular events. So by that I mean heart attacks or blockage to the veins, to the arteries going to their legs. So you can see it's about the same as the general population with imatinib and dasatinib, but quite a lot higher with nilotinib. And patients on dasatinib develop what are called pleural effusion. So this is like a pleurisy, like fluid around the lungs. And so there's different side effects with these different drugs. Whereas imatinib, although it has some side effects, there doesn't appear to be any long-term serious side effects. For those people who find graphs easier to look at, this is the risk of having a heart attack or a blocked artery to the leg with nilotinib. So that's the blue and the orange, and the green is imatinib. So we have to balance that. So when we choose a drug, we look at, if a patient's had a heart attack or had previous, angina, using nilotinib may not be a good idea. If a patient has had lung problems or pleural fluid around the lungs or heart failure, using dasatinib may not be a good idea. In New Zealand, we have a clinical trial that's all the New Zealand centres are involved with, and some of you may be on this study. This is a trial that's sponsored by the LBC, and we call it the KISS study. So patients, what we're doing is patients have the second generation drug, dasatinib, up front. So that's their first treatment. And so the aim is to get patients to get the benefit of that quick and deep response. And then at 12 months, if you've got that deep response, we change to the safer imatinib. And that study has now just got over 60 patients recruited to it, and we're aiming to recruit 100 patients. And this will help inform and will add to the knowledge around what's the best upfront treatment for patients. So just summarising where we are, what the new things are. Initial treatment is that we've got first and second generation drugs. In New Zealand, we have imatinib as funded for first-line treatment. It's got a good safety record. Dasatinib for high-risk patients, or if a patient goes on to the KISS trial. And so most patients would have imatinib outside of the trial as their initial treatment. The decisions around your treatment are based on other illnesses or comorbidities that a patient may have, and also the risk status. So patients perhaps with higher risk chronic myeloid leukemia, we may want to use a more powerful drug to get control of things quicker. Just to say, are we out of keeping with the rest of the world? The UK have just published their updated guidelines, and they recommend imatinib as their initial treatment outside of a clinical trial. So I think we've got appropriate treatment for our patients in New Zealand. The second topic in terms of what's new or what's changed is probably not changed so much. It's just some slightly different language, but I think is still, I've put a slide in because I think it's really important, and that is the monitoring of patients. And so when we treat a patient, is that we don't, it's not just getting the blood counts back to normal and the patient feeling well and their spleen going back to normal size. We actually want to put the patient into a deep remission and what we call a molecular remission. So this is actually from I think I borrowed this from Novartis, from one of their handouts, but here's a patient at diagnosis, and the black dots represent, in a diagrammatic form, the amount of leukemia that a patient has, and we estimate it's 10 to the 12 leukemia cells. When you're in remission, so your blood counts are normal and the bone marrow looks normal and the spleen's of normal size, there's still a lot of leukemia shown here by, less dots, but there's still a lot. And what we really want is to get right down to sort of no dots or hardly any dots. And we do that by doing molecular monitoring, and we look for that, that gene, the Philadelphia chromosome, or the BCR-ABL sort of gene, and we use that as a marker of the leukemia cells, because it's not in normal cells, it's only in leukemia cells. And your hematologist has probably talked to you about your molecular studies, or they may use the term PCR, and PCR is it's like a molecular photocopier. It's a way of taking a few cells and then taking the DNA or the RNA and sticking it in your photocopier, and then making not just 4 or 5 copies, but making 1 million copies, and then seeing how many of them are normal and how many of them have that BCR gene. And it's the same strategy when Dr. Bloomfield and Jacinda Ardern stand up at 1 o'clock and they talk about how many new COVID patients. All of that testing for the COVID virus, it's done on PCR, looking for the virus DNA. So we amplify the DNA out of the swab taken from the back of your throat or the back of your nose. And so all of our CML patients will have monitoring done every 3 to 6 months. And what we're looking for is the level of that Philadelphia chromosome, or the gene, the BCR-ABL. And we present it or express it not in an absolute, but relative to a housekeeping gene, or a gene that's always going to be present at a constant number in your blood cells or your bone marrow cells. So the level is expressed as a percent. So when you're diagnosed, the percent may be 80% or 100%. And then when you're in remission, the percent level is less than 10%. So the blood counts are normal. And then we want to get into a deep molecular remission. And that's when the levels go below 1%. And we can detect right down to levels of 1 in 100,000 or even 1 in a million normal cells. So that's what we're doing in these right-hand panels. So we talk about, and your hematologist will talk about milestones, and milestones is where on these international guidelines, where we would like patients to be after 3 months treatment, 6 months treatment, 12 months of treatment. And there's optimal, then there's a level of, well, it's okay, but we could be better. And then there's levels that these are unsatisfactory and we think about changing treatment. And there's a couple of key points. One's at 3 months, so we like the level to being less than 10%, or, there's probably no difference between 10 and 12%, but we don't want to see it still at 80 or 90% after 3 months. And then at 12 months, we like to see the level less than 1% and ideally less than 0.1%. So these are targets that your hematologist will talk to about, and they're really important. And there's a new term that's come out that's moved into the language, and we call this a deep molecular remission, and that's when the levels are down to less than 0.01%. So these are very low levels. So this is sort of between here and here. And depending on what city you're in, and some of the labs will test down to 0.01%. Our lab, we test down to 0.001%, down to 5 logs. But anything below 0.1% is great. And then these deep ones, they're even better. And that's the group of patients where we can think about sort of stopping treatment. So that's the second sort of thing that's it's not so much new. I think it's just that we've become aware how really important it is. The third topic that I wanted to talk that really is new, and I think has moved from being, gosh, can we do this, to this is now part of our treatment. This is something that I need to be discussing with all my patients. And it's the question of, do I need to take imatinib or dasatinib forever, or is there going to be a point where I could stop the drug? And there's a term that has been introduced, a new one called treatment-free remission. And the last time a couple of years ago when I did a talk around this at the patient forum, is that we're going, well, are we ready to do this yet? And perhaps it still is part of a trial. I think the big change is treatment-free remission is now, it's a goal. It's one of our goals of treatment. So our goal of treatment is minimizing side effects, getting into a deep molecular remission, and a treatment-free remission. So that's been a big move, and it's probably, of all the things I'm talking about today, that's the big change, that move to a treatment-free remission. So why do we want it? Why do you, or why would we like our patients to be able to come off treatment? And I get there's a number of reasons, and they're different for different people. Part of it is that you're coming off treatment is closer to the concept of cure, so that's important. Secondly, as I've shown you, these treatments are not without side effects, and so we can minimize that side effects. Thirdly, is that it's very well for me just to say you've got to keep taking these tablets. You shouldn't miss them. Even if you miss 1 or 2 a week, it's that's not a good thing. And then I look, how often do I complete a course of antibiotics? How often does Matt here complete his medications? We're not good at it, so we acknowledge it's hard to finish all your treatment. Not so much an issue in New Zealand because we're a publicly funded health system, although you could say, well, there's a cost to our health service, and if we can save money, it means we can put it into other treatments. But in the US, where patients are paying for this treatment or their insurance company, it's a big issue. And also for patients, for younger women who still want to complete their family or have family, is that we don't advise becoming pregnant while taking these medications, because there is a risk of affecting the baby. So there's a number of reasons for wanting to stop treatment. And it's moved into, we've got lots of evidence that it's a safe thing to do. And I'm not going to show you all the studies, but because they all look very similar. But this was the first study. So this was the French stopping imatinib study, STIM study. So these were patients that had been on imatinib for at least 4 years and had been in a deep molecular remission. So they'd been PCR negative for at least 2 years, and they stopped their imatinib, and about 40% of patients remained in remission. So on the y-axis, this is the number of patients remaining in molecular remission, and the x-axis is time. So about half to 60% of patients, they became PCR positive again and went back onto treatment, but about 40 or 50% of patients remained negative, and they remained negative off treatment. And the important thing was that those patients that had a molecular recurrence, so they became positive again. So they didn't have a clinical relapse, it was just a molecular recurrence. They all responded to going back onto imatinib. So this was a safe treatment, a safe thing to do, and it meant patients could come off the treatment. This is probably the biggest study. This is the Euro ski study. So this was, again, looking at stopping imatinib over multiple European centres, nearly 800 patients. And again, you can see almost identical. So at 6 months, 61% of patients remained in remission, a few later recurrences, but around 50% of patients have a durable remission stopping treatment. And so this data, and it's now been demonstrated across multiple trials. So this is trials of stopping imatinib, 10 studies across all the continents, and if you just look at the right-hand panel, this is the number of patients remaining in remission. It's between 24 months and 5 years. And you can see they're all very similar, somewhere around 40% to about 60%. This is it for the second generation drugs. So this is, sorry, it's not for this imatinib, it's for dasatinib and nilotinib, but almost identical data. So we've got, over 2,000 patients, nearly 20 trials, all with very similar studies show that we can stop these drugs. About 50 to 60% of patients will remain in remission. And for those patients who become PCR positive again, we can restart their imatinib or their dasatinib, and all the patients go back into remission. So answering the question, are we there yet? Is this safe? Not only are we there, but this now should be a standard part of treatment. So when we see a new patient with CML and we're discussing the diagnosis and our treatment recommendations, part of the discussion should be around that, in the longer term, we're looking at the potential for a treatment-free remission, that we can come off the drug. As I said, about 50 to 60% of patients who have a trial of stopping treatment remain in a remission, and all these new evolving international guidelines include recommendations. So, can everybody stop their drug? No. It needs to be. We've got better at predicting who are the patients who will benefit from a trial of stopping. So it's not something you do early. Generally, you want patients to have had 5 to 6 years on their treatment with imatinib or dasatinib or nilotinib, and that's probably because it means you're in a deeper remission, and so that predicts for a better chance of staying in remission. Secondly is that if you're in a remission but it's not a very deep one, then there's a high probability of the PCR coming positive again. So we need patients to be in a deep molecular remission, and ideally the longer you're in that deep remission, the better. And this is from the Eurosky trial. So patients that have been in a deep remission for nearly 5 years, nearly 80% of those remained in remission on stopping drugs. And there's some hint, and there's a lot of work going on trying to look at other clinical and biologic markers that may help us better predict what patients are going to be in a stable sort of remission. So, are there any risks of stopping your imatinib or dasatinib? So, as you've seen from those curves and data, 50 to 60% of patients remain in remission, but that means that 40 to 50% of patients will have a molecular relapse. So it's not a clinical relapse. So it's not going back to how you were when you first presented. These are very, these are just picked up on the blood tests, and most of them almost are in the first 6 months. So 90% are in that first 6 months. So because of that, is that if we're going to do a trial of stopping treatment, is that we need to be able to do monthly sort of blood tests. So I felt that during the lockdown, when the labs were under pressure, was not a good time for a stopping therapy, because the labs weren't there and we couldn't reliably do those monthly blood tests. So if we're going to do it, we have to, as a patient and their doctor, commit to doing in that first 6 months a blood test every 4 weeks for the molecular monitoring. Something we've only just come to realize in the last year is that there are some later relapses. So about 10 to 15% of the recurrences occur after 6 months, and some of them are after 2 years. So even though you think, gosh, I'm going to be able to come off the medication and I won't have to see that Dr. Browett again, is that we need to continue the monitoring, and at about 3 monthly, and it's a lifelong sort of monitoring, because there's still a risk, even though it's very small, of it coming back. And the final risk is that thing that patients worry about is, well, if I stop and it comes back, how I know it's going to go back into remission again. And we're reassured by the data that in all the studies from across all of those continents is that 99.9% of patients have responded again and have gone back into remission. So we think it's safe. The other risk of stopping is that there is a new syndrome that we've learnt about, and some of my patients have developed this, because I think we didn't really know about it when we started doing it, but it was called the withdrawal syndrome, or the TKI withdrawal syndrome. So when we stop the imatinib, is this syndrome about 30% of patients, and it's a bit like a fibromyalgia. So it's arthralgia. So arthralgia is pain in the joints, but without swelling of the joints, and stiffness around the sort of muscles. So particularly in the hips and the shoulders. It occurs about a month after stopping, and usually is sort of self-limiting, but can continue on for several weeks to months. The early literature said this is mild and is relieved with Panadol. My experience in patients is that sometimes it is, but some patients it's need slightly stronger pain relief. So it can be an issue. We don't know why it develops, and it develops in patients that have been on their imatinib for longer. Have it more. If you're in a deeper remission, you have it more. So it might be a good prognostic marker in a way. And if you've had musculoskeletal symptoms prior to coming off, then that increases the risk. I'm going, that's a really hard one to sort out, because most of us have some musculoskeletal sort of symptoms. So this is a new syndrome that we need to talk to you about if we're going to go into stopping. So there are international guidelines, and these are our recommendations for, these are the patients that we consider, and they're just guidelines. So guidelines, you don't have to fulfill all of these, but they're just to help us. So we would only recommend it for patients that were in chronic phase, so not the more advanced stage of accelerated phase. And you have to have a molecular marker that we can follow. There's a small number of patients have these very rare rearrangements, and we can't accurately monitor and follow those. Patients need to be on their initial treatment with imatinib or have changed treatment because of side effects rather than resistance. So we're reluctant, just on our current knowledge, if a patient has not responded well to imatinib and then has gone on to dasatinib and has had a good response to dasatinib, that's riskier. We're not so keen to recommend stopping there. Having said that, I've done that in a couple of patients and done that sort of successfully. So it's not an absolute, it's a relative. As I mentioned before, the longer patient has had imatinib or dasatinib treatment, so we like to see patients on their treatment at least 5 to 6 years, and in a deep molecular response. So I've written here MR5, so that's 0.001%. The newer studies are showing that perhaps just being less than what we call 4.5 log or 0.003% is. So don't have to be negative, but very low levels. Patients and their labs and their medical teams need to be able to commit to that regular monitoring. So we recommend every month for the first 6 months, every 6 weeks for the next 6 months, and then 3 monthly indefinitely thereafter. And a change from the early studies is what we call a loss of response or a failure. We don't mind if in the monitoring the patient goes from negative to positive, because they may go back to negative again. The critical level is what's called an MMR, a major molecular remission. That's a level of 0.1% or more. So if it becomes greater than 0.1%, then that's an indication to go back onto imatinib or dasatinib. So the level, we can have weekly low levels, and that's fine. There's no issue with that. But if it's above 0.1%, that's a sign that we need to put our patient back onto imatinib or dasatinib or nilotinib. If you've had one trial of stopping and have gone back onto it, is that it? Does that mean you can never come off it? And no, I think there's a lot of studies coming out of, perhaps if you change treatment or, have some longer treatment, there is some success and recent reports of patients having a second trial of stopping. This is a French study where they had 31 patients who had a recurrence after their first trial of stopping, and they had a second trial, and about 40% of those patients were able to successfully come off drugs. So, let me just go back. So the blue line is the second treatment-free remission. The green line is the first. So, don't be disheartened if you have a molecular recurrence and go back onto treatment. We will still, I think it's something, there's new knowledge coming out, so it's possible to try to have a second trial. What happens if we have a discussion and we suggest to you, you may like to think about it? Is it the right thing for you? Is it the right thing for everybody? No, it's not. And there's, studies show, between 10 and 20% of patients can be considered for stopping treatment, but elect not to. I went to a talk from this man. This is Kareem Abdul-Jabbar. So that's ex-President Obama. So he's around 185 centimeters. That's Obama is that height. So Abdul-Jabbar is a basketball player who then became a leader in the spokesperson for the Black Americans, and this is him being given the presidential Medal of Congress. And he's got CML and he's on nilotinib, and his clinicians discussed with him having a trial of discontinuation, and he elected not to. He felt very comfortable remaining on his treatment. So not all patients want or need to stop treatment, and so because everybody has different reasons and motivation for it, so it may not be the thing for you. You may feel more comfortable remaining on your treatment. And this is an important sort of study. So this is a study done by the CML patient group. So this is the CML advocates group. So this is a study done by patients with CML, and it was basically trying to get a feel for the patient perspective. So how do you feel about stopping the drug and treatment-free remission? So this is all the countries shown here in light blue and dark blue, depending on how many patients sort of responded. So New Zealand centres, we weren't part of this, but it was a study of over 1,000 respondents in 68 countries. And so one of the questions they asked was, why did you want to consider a period of stopping treatment? Because doctors have got their views on why you would do it. So in this, patients could tick multiple quick answers here. So it just wasn't, you didn't just have to do one. So percentage across the top. So to get rid of treatment side effects. So that was the most common. So around 50% of patients. Fear of long-term side effects. So those vascular or other side effects, 40%. Avoidance of taking long-term medications, 40%. See if you can be treatment-free. That's important, 50%. My doctor told me to join a trial, 20%. Financial, 10%. And the pregnancy issue, sort of 15%. So those are the reason around side effects and that importance of being able to come off treatment. The other one, and this I found interesting as well, was what information did patients want to receive? And I assume by this is that they'd had the trial but hadn't properly or hadn't been given this information. So the results of the clinical trials published to date, information about each step of the process of stopping, what the risks were, the withdrawal syndrome, and any side effects on restarting treatment, and information on the PCR sort of monitoring. So interesting, I think important information for the medical teams of what's important to our patients if we're going to talk about treatment stopping. So this is my last slide. And so although we've made huge advances around in CML, and there are still new things for us and new things for us to learn. And I think the new things that have come, treatment-free remission is now moved from being the research trial or something for a few people to talk about. I think it is now one of our goals of treatment, and we need to be always discussing it. Secondly, is I think we've moved away from the leukemia, the way we so the way we talk about acute myeloid leukemia or others, is that their treatment decisions and are more based around greater importance around the patient, their minimizing side effects, basing treatment around any other illnesses the patient has. So I think it's a subtle change of the way we think about the condition, because we know the majority of our patients are going to have a normal life expectancy. So we need there's other important things to focus on. And thirdly is that molecular monitoring it's still key and a critical part of our management. So I'll stop at that point and happy to take questions. And Matt, I did see one that was once
Yeah, just going to say, Peter, wonderful presentation. Great to have these updates. This is fantastic. Yeah, there's a few questions we can look at it, as long as, if you can read it out and then kind of try to take a first one is long-term data.
Okay. Excuse me. Is there any long-term data around risks such as reduced potential to reach deep remission again for those who had a period of treatment-free sort of remission? So that's really, it's a really good sort of question, because I think that, you know, it was our initial fear, and it's why we felt this should only be done as part of a clinical trial. So I think all of those trials show that patients go back into a deep molecular remission again when they reinstitute treatment. I think it's important, though, there's a lot of caveat around that, is that if we do it, you know, the monthly monitoring, if patients had that molecular relapse, it's important that the treatment is reinstituted reasonably sort of quickly upon demonstrating that. So the kinetics of, I think if it's not acted on and the levels, you know, we wait another month and another month, is that creates a risk. But no, I think it is, we've got good data and reproduced across all the studies. And related question, is there any difference between the first and second generation sort of drugs? The data is very similar between those two compilation tables. So the first was 10 studies with imatinib stopping after imatinib, the second 8 studies after stopping the second generation drugs, and that the data is almost sort of identical. I think one of the interesting things is that could we, if we use the second generation drugs, would that increase the number of patients who are able to be considered for a trial of discontinuation? Or if we had a patient who perhaps had a trial of imatinib and then stopped on imatinib and had come back, and then should we go to a second generation drug to try and get into a deeper remission? And I think we're still, those questions and those trials are underway. So, you know, would it be better with a second generation drug, or if it didn't work the first time, could we go to a second generation drug? So I think that those are still questions to be asked. What is the risk of CML transitioning to another leukemia, such as acute myeloid leukemia? Another good question. So the natural history of CML. So prior to 2001 and the advent of these tyrosine kinase inhibitors, that was sadly the natural history of CML, is that it would progress into accelerated phase and into acute leukemia, either acute myeloid leukemia or acute lymphoblastic leukemia. That occurs, it still occurs, but it occurs very infrequently sort of now. And so the majority of patients will respond to tyrosine kinase inhibitor therapy. The risk is highest in patients who don't respond or don't reach those sort of milestones. So it seems to be the more leukemia that a patient has, then the higher that risk of transitioning into an acute leukemia. So when your levels are below 1% and below 0.1%, but is that the risk is very, very low. I can't recall recently a patient who is progressed in that situation. So we really see that progression in patients that have not reached their milestones, and that's one of the rationales for the KISS trial. So we're using our more powerful drug in the first 12 months, so we get the quicker and deeper response, but then we change back to the imatinib so we avoid the side effects. So our hypothesis that we're testing is that we get the advantage of both drugs, an early response and a deep response, but then it's without a risk of side effects from the treatment.
Thanks for that, Peter. There's another one down there if you can see it from Erica. Very interesting presentation. Could you say something more on any psychological effects of patients for stopping treatment?
I think it is. I think it's an area that, and it is dealt with around the in the CML advocates study, and I think there is the data around the levels of anxiety around that sort of stopping. So they look to assess that. So I think it is an issue, and I think it's something that needs to be sort of discussed. And I think you come back then, it's perhaps not for everybody, because you're balancing up, you know, what are the benefits of coming off the drug. So it avoids any side effects that a patient may have at the time, the potential for any long-term sort of side effects, and then that feeling of being off your you know, off drugs. It's balanced though by that, you know, there's, even though we've got the data that I've shown here that, you know, that in the small number of patients, or sorry, the patients that have a molecular recurrence, is that they all respond to, you know, going back onto their drug and go back into remission again. You know, I acknowledge there is an anxiety there around, you know, well, perhaps that won't happen. And also some patients, when they first went onto treatment, had side effects of going, and so that's come up in a couple of discussions I've had with patients of concern around the sort of side effects of going back onto their TKI, whereas they're stable on their TKI, and so it's easier to remain on the TKI. So I think really good question, and I think it actually needs to be, needs more research on in that area.
Yeah, thanks for that response. Hey, I can see one just at the bottom, Peter, if you can see, it says, "Thank you, Professor Browett, for such a clear and helpful presentation. Is there any reason why leukemia appears to be more common in men than women?"
Every medical condition is more common in men than women. It is just a burden that we men need to bear. Look, we don't know why that CML is more common in men in seriousness. I don't know. It is yeah, and you know, because there's not a, you would expect, you know, because we don't recognize environmental factors or environmental exposures that cause the Philadelphia chromosome to form. And so, you know, there's not a recognized environmental, you know, occupational risk. There doesn't appear to be an inherited predisposition that would be different between men and women. So no, I think it's a good question, but I don't know the answer to that.
Yeah, no worries. Good question. Thanks for that. Hey, and Peter, this is on behalf of a patient off the call. They just wanted to ask, when it comes to fatigue, do you have any comments about CML and fatigue, and does it start to subside like once people are getting a deep response and it's under control? Is that sort of a trend?
Yeah, absolutely, yes. So unless the fatigue is a complication of a side effect of the medication, and sometimes I find that quite hard to you know, to untangle, because and I didn't put the slide in with the, you know, but it is, we do recognize it, and it came out in the in the patient survey, the patient perspective study, as well, as the fatigue was an issue. So I think some of it can be a medication related effect, in which case then the question is, well, could you, you know, is it potential to do safely do a dose reduction and see if those symptoms resolve, or in the longer term aiming for a period off treatment? Yeah.
Okay. Thanks for that.
Yeah.
This might have to be our final last quick question. This was another patient off the call. What is it here? So it looks like, you know, roughly 40%, you know, have a treatment-free remission, and then you had a slide about how maybe about 10 to 20% of patients just choose not to actually, stop.
Yeah.
Do you think the numbers might even be a little bit higher, considering that those people were candidates? They had,
Yeah. No, because making the assumption that those patients are representative of the patients that have gone onto the clinical trials. So I think probably not. What I think though is that I think we're going to get better at predicting the patients that have got the highest chance of remaining in that remission. So along the lines of, the deeper your response, the longer you're on. So patients that have perhaps been on their imatinib for 7, 8, 9, 10 years and have been, PCR negative for 4 or 5 years. I think that group of patients are likely to be not around the 50%, but they're, potentially up to 70, 80% of those patients would remain in remission and off treatment on stopping. So I think, being patient or a patient is, and staying on the drug for longer may increase the chances of being able to stay in a good and durable treatment-free remission is helpful.
Okay. Well, I really appreciate you answering that and taking the time with all of our questions. So I think we'll have to wrap it up. And hey, just wanted to say, on behalf of LBC staff and the patients, that we serve across the country, we're really big thank you to you for carving out your time today. And we understand that it may or may not be your birthday today. So bonus for you coming out on your birthday to actually talk to us. So thank you. Big thank you. Deep appreciation. So yeah. Yeah.
Okay. Cool.
Otherwise, go well. And there you have it. Yep. Professor Peter Browett.
Okay. Thank you.
Take care.
Someone's been gossiping.